This is the overview of my talk. I'll be discussing epidemiology in brief, the definitions used to define GE junction endoscopically, the diagnosis, the role of endoscopy for pre-malignant and malignant lesions, and the adjunct modalities we use, the role of endoscopic ultrasound in GE junction tumors. Lastly, of course, I'll be discussing in brief the treatment, both endoscopic resection and palliation, and I'll be discussing in brief endoscopy in the management of hydrogenic leaks. So coming first to epidemiology. Now, cancers of the esophagus and stomach are the most common sites globally for GI cancers. They account for about 10% of the global cancer burden overall, as per Globocan data. And 30 to 35% of esophageal cancers involve the lower esophagus, and 18 to 20% of gastric cancers usually arise in the cardiac. And clearly, there is some ambiguity in labeling, and which is why this entity of GE junction cancer is often labeled as lower esophageal cancer, may be labeled as a cardiac cancer, and people do not often refer to the diagnosis as GE junction cancer. But if you actually look at the incidence, there is an increased incidence of tumors that involve the GE junction amongst the distal esophageal cancers in the US. This data from the 1970 to 2013, if you actually compare, there's almost a twofold increase. And in the West, it has been found more in white males and those over 65 years, typically correlating with features of GERD, which is also more predominant in this group. Now, if you actually look at the incidence of esophageal adenocarcinoma and GE junction adenocarcinoma over the years, you'll find that in North America, it's almost remained the same. In Europe, there has been an increase, but again, in Southern Asia and Eastern Asia, there's again an increase that is seen over the years. Now, again, these are largely accounted for by risk factors. Now, of course, GE junction tumors can either be squamous or adeno, but adeno becomes the predominant type when it comes to GE junction tumors. And the risk factors for adeno we know are smoking, GERD, Barrett esophagus, and obesity. And as these risk factors tend to increase, the incidence also tends to increase. But is it actually the case that adenocarcinoma is increasing in India or not? Is still remains a question. So if you look at the temporal trends in India, this is a summary of the different studies of esophageal cancers that I have made. So if you actually look at it, the first study on lower esophageal tumors published from PGI in 2001, they found adeno was around 69 out of 169 patients, around 40%. And again, if you actually look at data from Chennai, lower esophageal cancers of almost 50%. Overall, the rate of adeno was same. They looked at the temporal trend between 1990 and 2004 between adeno and squamous. They found no change. Again, from Calicut, no change in temporal trend. This is data from Kumau, which did not, again, the site was not mentioned, but if you look at the paper, a large number were lower esophageal. So again, predominantly squamous. Again, if you look at data from Mumbai, this is from Hinduja, they found no change in the temporal trend. If you look at data from Sion in Mumbai, again, no change in the temporal trend. And if you look at lastly, data from TMH, almost 8,000 patients, around 12% being GE junction tumors, they found 4:1 squamous to adeno, and there is no change over the last almost 20 years. So clearly, although adeno is overall incidence of cancer is on the rise, the predominant type of esophageal cancer may remain squamous, and the site of the cancer is almost remained the same over the years. So it's not like as a proportion GE junction is actually increasing. Now, if you look at the definitions used to define GE junction endoscopically, now there has always been a dispute. Some people actually used the ora serrata or the Z line often to describe it endoscopically. Again, if you look at it, the proximal end of the gastric folds can be used to define the GE junction endoscopically. As you can see here, this is the proximal end of the gastric folds, or the lower end of the esophagus showing the palisade vessels can be used. So again, there's a lot of dispute and debate on this. So there's a recent Kyoto consensus that was published in Gut around 3 months back. And they said that the distal end of the palisade vessel seems like a better landmark as compared to the proximal end of the gastric folds, because there are some issues with taking the proximal end of the gastric folds as a landmark. You can see here that optimal inflation may often be an issue. For all of you who do endoscopy as part of their practice, you might find that based on the inflation, the position of the proximal gastric folds may change, and which is why it seems that the landmark of using palisade vessels is better. Now, why we need to know this is that often pre-malignant lesions like Barrett's or in the presence of hiatus hernia, diagnosis or the exact location of the GE junction becomes of critical importance. So we'll go to diagnosis of the role of endoscopy for pre-malignant and malignant lesions of the GE junction and the adjunct modalities that we use. So again, in pre-malignant lesions, the most common, of course, is Barrett esophagus. You can find esophagitis in these patients, but I won't go there. But clearly, Barrett esophagus is a precursor lesion for CA of the GE junction. So diagnosis is very critical because if you know Barrett, then you will surveil these patients and eventually you can diagnose early cancers. So there was an older classification where you used to describe it by short segment or long segment. But now we use something called the Prague classification, wherein you look at the circumferential extent from the true position of the GE junction. Now, again, in the Prague classification, they took it as the proximal end of the gastric folds. Again, in the recent Kyoto consensus, they changed it to the palisade vessels. But nevertheless, it is used as the proximal end of the gastric folds in this classification. So from the proximal end of the gastric fold, the circumferential extent is taken. Let's say here it's 2 centimeter, and the tongue, the tongue that extends maximum above, that is the maximal extent. So the C and M, the circumferential extent and the maximal extent, have to be reported. Now, why this has to be reported is that the length becomes critical to decide how we are going to survey these patients. A longer segment of Barrett with a longer length of tongue will require surveillance more often because the changes have occurred more, there are more severe changes that are related to GERD, and there is a higher risk of developing malignancies in these patients, and which is why the surveillance interval may change based on the length. Again, sampling in Barrett esophagus is of critical importance, and we should know the protocols for biopsy. So often they use something called the Seattle protocol, wherein they do 4-quadrant biopsy every 2 centimeters. So every 2 centimeter in the length of the Barrett, they will do a 4-quadrant biopsy. Now, why this is done? Because clearly, if you do a non-systematic biopsy sampling versus a systematic biopsy sampling, the chance of detecting dysplastic lesions or early esophageal adenocarcinomas is much higher. But again, there is something new that has come in. This is called wide area transepithelial sampling. So it's a cytology brush of kind, but there is a computer assisted analysis here. So apart from biopsy, you can also do this wax 3D now, wherein you take a brush in addition to the Seattle protocol. And again, this increases the yield by maybe another 10% to detect dysplasia. Now, basically, Barrett may lead to early esophageal adenocarcinomas, and diagnosing them is very important in these patients, and which is why there are different image enhancement modalities which will help us detect these lesions better. So one of them is the use of acetic acid. Now we use plain vinegar in our setup. So the vinegar that is available in your kitchens can be used with 1:1 dilution with water or with saline, and we spray it over the mucosa, and you will see something called acetowhitening. So this is acetowhitening that is seen in the Barrett mucosa, and lesions may get highlighted better. So for all of them, all of you who do endoscopy, acetic acid is easy to use and may help to point out lesions in patients who are having Barrett. So if there is no acetowhitening, again, with some classical changes, you might think that this is neoplastic. And of course, with the advent of newer endoscopes, there's a lot of image enhancement techniques that are used with the touch of a button. So now we have endoscopes which can help us, which are high definition endoscopes with certain image enhanced modalities. Now, narrowband imaging is available in all Olympus scopes. It's the most studied modality. And clearly, based on narrowband imaging pattern, we can again detect lesions of dysplasia in patients with Barrett esophagus. So there is something called the Bing classification that we use for mucosal pattern and vascular pattern. And based on this classification, we can actually detect with a reasonably high accuracy of around 85% presence of dysplasia in patients with Barrett esophagus. Now, what all do you report in a patient with Barrett? Now, apart from, of course, the Barrett length, which we talked about, the Prague classification, you report, of course, about the different islands. You talk about any concomitant hiatus hernia. If there are any visible lesions inside the Barrett, like we talked about after using acetic acid, the classification of these visible lesions. Now we use something called the Paris classification for superficial tumors that can be used because that will actually help us determine if they are removable endoscopically or not. And of course, the biopsies and the location and the number of biopsies that have been taken from the Barrett. So this is a classical reporting. This is given by the British Society guidelines. So this is something that has to be reported in every patient with Barrett. Now, what about GE junction tumor? Now, there are a lot of patients who might have tumors without a concomitant Barrett. Now, in those situations, we use some classifications. Now, the Sievert's classification is the most commonly used. Again, another name would be the Sievert-Stein classification. Now, type 1 would have an epicenter within 1 to 5 centimeter above the GE junction. Type 2 with an epicenter within 1 centimeter above and 2 centimeter below the GE junction. And type 3 with an epicenter 2 to 5 centimeter below the GE junction. Now, again, there is the Japanese classification or the Nishi classification, wherein a tumor less than 4 centimeter in diameter with an epicenter located within 2 centimeter of the EGJ is considered as a GE junction tumor. Now, again, in the Japanese criteria, it is a little more stringent. So the Sievert's classification gives us more leeway to classify more number of tumors as GE junction tumors. Now, question largely becomes, what is the relevance of actually doing this? Now, the mapping actually helps us in two things. One, of course, deciding the surgical approach, and also deciding the lymphadenectomy that is actually required, because based on the type, the amount, the different the lymphadenopathy that may be present in these patients may differ, and the requirement for lymphadenectomy may differ. Also, there have been studies which say that survival in Sievert 3 is much worse than Sievert 1 or 2. Now, although this has not been substantiated by multiple large studies, because the data on GE junction tumors still remains less as compared to esophageal and gastric cancers. But again, there is data to suggest that Sievert 3 tumors have a worse behavior as compared to Sievert 1 and 2, and helps us prognosticate these patients. Now, coming to endoscopic ultrasound, what are the applications of EUS in these patients? Now, EUS, they can be either a radial EUS, which can help us detect the layers, or they can be a linear EUS, which helps us to perform sampling or do some therapy. Now, EUS can be used for T staging. The accuracy is reasonably high, but this accuracy is largely for luminal tumors. The highest accuracy is typically for T3 stage tumors, wherein you're able to detect, disease going past the muscularis propria, and the accuracy may be as high as 88%. T3 followed by T2 followed by T4 followed by T1. But this data is largely extrapolated from esophageal cancer. Now, typically, this is used in situations to decide on role of upfront surgery, that is T2 versus T3, and also prior to endoscopic resection to decide if it's resectable, whether it's T1A or T1B, whether to send for surgery or not. And again, in situations where the patient may be upfront operable, you might find a single node, let's say in the subcarinal region or an AP window region, or a paratracheal or an abdominal node. You might want it sampled to detect if there is an extra, there is a nodal metastasis, and to decide if the patient actually requires any neoadjuvant therapy prior to surgery. Now, of course, there are fallacies in EUS, unfortunately, in the GE junction, because EUS is difficult to perform due to the angulation at the GE junction, which makes interpretation rather difficult in these situations. Now, this study was published in Annals of Thoracic Surgery in 2015, and you see that in the T1B and in the T2 stages, there is significant amount of overstaging that is seen. So typical correlation in GE junction tumors with the pathologic T state is only up to the tune of 48%. So let's say 50%. And inaccurate staging is high in UT1B and UT2, wherein it leads to overtreatment. Again, longer tumors are better staged than shorter tumors. So if there's a small tumor, it becomes difficult to stage and is often overstaged. And maybe the patient may undergo a more radical surgery than what is actually required. Coming next to treatment, endoscopic resection and palliation. Now, there are different modes of endoscopic resection. Now, we can do endoscopic mucosal resection, which is easy to do, wherein you inject the base of the tumor, you lift it and you cut it. And it can be done with a single channel scope, with a double channel scope, or there's something called a CAP EMR that can also be done. Endoscopic submucosal dissection is a little more controlled, wherein you mark the lesion, you inject, you cut the base, you dissect underneath in the submucosal region and slowly take out the tumor en bloc. So clearly the rate of en bloc resection would be much higher if you're doing this, wherein you're doing a more controlled method as compared to endoscopic mucosal resection, wherein we're just injecting and removing with a snare. Now, issue is, when do you do a conventional EMR, when do you do an ESD, and when do you send for surgery? So if you actually have an early cancer at the GE junction, you really need to decide if a patient is suitable for endoscopic resection or not. So you largely depend on the Paris classification, wherein you look at the Paris types. Anything with Paris 2C or Paris 3 cannot be endoscopically removed. and it is best that these are sent for surgery. Again, Paris classification, the image enhanced endoscopy appearance, the presence of Barrett esophagus will decide what further therapies are required. And of course, the cross-sectional imaging is often required. Then in patients with an associated Barrett esophagus, you can, apart from the EMR or ESD, you might require adjunct therapies in the form of RFA, cryoablation, or APC. And in no Barrett's, of course, you don't require them. And EMR or ESD of the visible lesion can be done. Now, EMR is often done as part of staging, wherein you remove the tumor, you see the base. If there is infiltration at the base, you send the patient to surgery, or it can be part of therapy. Now, again, ESD, it is commonly done in expert hands. It's more time consuming, done at few centers only. Again, it can be done as part of staging or as part of therapy, but less often as staging as compared to EMR. So this is again a patient we had. This is a Barrett esophagus. You can see the aceto whitening that's normal. This is a Paris 2B flat lesion seen. This is the area which is normal. We were able to see confirmed with MBI. This is a dysplastic focus. This patient underwent an EMR and subsequently we did hybrid APC for this patient. So again, when do you choose EMR and when do you do ESD? So there is clearly a higher R0 rate with ESD. If you look at the two major trials, one was, this is German data of around 63 patients. They found that the rate of R0 was higher with ESD, but there was no difference in recurrence. On the other hand, data from North America would say otherwise, wherein they say that there's a higher R0 with ESD, but there is a lower recurrence. And there is a higher need for additional procedures in the EMR group. But in centers with expertise, clearly, you can choose ESD over EMR, but adjunct modalities have to always follow in Barrett's mucosa. So there is something called different types of ablative therapies that are used in Barrett mucosa. So the reduction in risk of recurrent lesions after thermal ablation is high. So which is why you have to do these ablative therapies after doing a resection of a visible lesion in Barrett. So the potential options include RFA, cryoablation, or APC. Now there's something called hybrid APC, wherein you actually do submucosal injection throughout the length of the Barrett, and then you do argon plasma coagulation to burn, so that there is lower injury to the muscle with similar efficacy. Again, there are some patients who are poor responders to ablation and have a high recurrence. Now those with Barrett's epithelium, which which regenerates on the base, those with a narrow esophagus, those with ongoing reflux esophagitis, and those with neoplasia in the Barrett esophagus for a long time are all, those who are poor candidates for ablation. Now going over to palliation. Now self-expanding metal stents remain a potential option. Now they alleviate dysphagia and improve quality of life. They're clearly never done as a bridge to surgery. The absolute indications, of course, remain tumor leak or rupture and fistulae. But in patients who have dysphagia, it's a relative indication if any other therapy can be offered. Other therapy in the sense that if the patient is going to undergo any other therapy in the form of chemotherapy or something, there is a potential option wherein the tumor may shrink and the patient dysphagia may get relieved. Then you might as well wait before you put a stent, because sometimes after therapy, there is a risk of complication and the stents migrating into the stomach. Again, if there is recurrent dysphagia after prior palliative therapy, then you can consider a SEMS upfront. Now, what are the practical considerations? Now, these are, of course, the indication, the location and length of tumor, the performance status, and median survival. Now, all these have to be considered. Now, of course, there are stent-related factors that you also need to consider. If fully covered, you'll only place in situations with benign disease. So partially covered is the way to go. Again, proximal or distal release, often in patients wherein you're not able to go across the tumor, you might place a proximal release, but distal release may also be can also be used. Again, a large flare may be used in situations where the tumor burden is less, wherein the narrowing may not be significant, but the patient is still very symptomatic. And lastly, of course, there is the anti-reflux stents are in vogue. And there is a lot of debate on whether to use anti-reflux stents or standard stents. But again, I'll come to that in detail. Now, this is again a patient of G junction tumor. We placed an esophageal stent across the G junction in this patient. Usually done the fluoro guidance over a guide wire. So it's easy to, these procedures are easy to do, but of course there are implications. So clearly the choice of patient remains very critical. Now, stenting across the G junction. Now, G junction tumor, the issue largely becomes that the stent will cross into the stomach and often leads to significant reflux. Again, after therapy, there's a significant risk of migration. So there's something called the esophageal Z stent, which was developed by Dua to prevent reflux in 2001. But again, After that, there are multiple different types of anti-reflux stents that are available. Again, there are anti-migration stents that are also available. Now, this is an anti-migration stent that is available in the market from NITI. But clinical data to support the use of these anti-reflux and anti-migration stents is not robust. Now, even a recent meta-analysis of RCTs published in the World Journal showed that anti-reflux stents, there was no difference in the rate of reflux, dysphagia relief, or migration as compared to traditional stents. So even though these are available in the market, a lot of people are using it, but data to support their use is still sparse. Now, what are the problems with these stents? The complications are reasonably common. Tumor ingrowth is the major issue. Patency rates at 6 months, maybe around 67%. So up to 30% will actually have some issues with the stent getting blocked by 6 months. Stent migration is reasonably more common, again, more common in those with benign strictures than those with malignant. Food bolus may get obstructed. So you need to have a strict regime. There is something called a prosthetic diet we prescribe to our patients, and that has to be followed. Again, major complications are rare, but they are more common in female patients than those with adenocarcinoma. So clearly the G junction tumors are the one where the risk of complication is higher. So you need to be more careful. Coming lastly to endoscopy in iatrogenic leaks. Now, again, there are multiple options that are available to us. There are different kinds of clips. There is metal stents, and of course, there is also endovac that is available to us now. So clips are typically used for small leaks. Now, this is a patient with gastric pull-up with the sleeve done. You can see a small leak from the sleeve side, which is closed with clips. Again, there is something called an over-the-scope clip, which can be used for larger defects up to 2 centimeters. So these are better than these through-the-scope clips. But again, the limitation becomes the size of the defect has to be small. Less than 1 to 2 centimeters, the ideal size where these can be used. Anything larger, you need to look at other therapies. So again, SEMS can be used for anastomotic leaks. Again, technical success is high. The leak occlusion is reasonably high, up to upwards of 90%. Oral resumption is quick in these patients, so they are able to take orally, within 72 hours in 3/4 of the patients. But issues largely become stent migration, which is a common complication. So which is why you need large flare stents. And again, often on, there's a preference to put partially covered in these patients because the stent may actually get embedded and stay there, but the long-term sequelae become a problem in these patients. So clearly, SEMS, although they are useful to start the oral intake and may occlude the leak quickly, but in the long term, there are a lot of sequelae. They might present with recurrent dysphagia. Patients have significant amount of chest pain. So, which is why other therapies should be preferred if possible. So the other therapy would be, of course, endosponge. Now, endosponge would be a sponge that is attached to a catheter placed into a leak or abscess cavity. And there is a continuous suction attached to this sponge, which actually promotes healing and collapses the wound cavity. Now, issues again with endovac, it's only made by B-Braun. The cost is very high, and there are multiple endoscopy sessions that are required. And of course, it's uncomfortable to the patient. Now, especially if you're looking at Sievert 1 tumors with a leak, you might actually have to place it close to the lung, and it leads to a lot of chest pain in these patients. So again, if you look at the recent studies, the data is very good. The pooled estimate for successful closure is upwards of 85%. And again, according to the etiology of the transferal defect, there is no significant difference. If there is a perforation or a leak or a fistula, endosponge usually works in all situations. So to summarize, G-junction cancers are often misreported as esophageal or gastric cancer. Localizing the G-junction is critical to report pre-malignant lesions like the Barrett esophagus. Endoscopic classifications are useful in mapping disease to plan the surgical approach. EUS role in G-junction cancers is largely to decide operability. However, there are some limitations. EMR can be used as a staging or therapeutic intervention. Now, ESD can be done in place of EMR in centers of expertise. Now, SEMS can be used for palliation with multiple practical considerations required before placement. And clip, SEMS, endovac, all are potential options in iatrogenic leaks, and we have to tailor the approach based on the size of the leak. Thank you.